Our next presenter is Dr. Aasim Padela. This time he will be talking to us about his reflection in terms of knowledge gap and healthcare inequalities in palliative care and end-of-life care. For Muslims, this time it would be more about...
Wait and see.
Okay.
So, it's been a very, very phenomenal morning for me. I hope you all have enjoyed it as well. I'm going to move to now, they'd want to talk a little bit about policy and sort of empirical approaches to address questions of disparities within the Muslim community in this domain. That's one of the undercurrents of why we're all here. Yes, to provide better support for patients and to better understand Muslims and Islamic sort of cultures, but also to think about what are the gaps in our knowledges to kind of move towards a more equitable healthcare system in this domain. So, let's see. All right, no disclosures. So another way to think about the research, now I talked a little about the theological earlier this morning, but now more in the empirical research that we do at our initiative is at this juncture, between the seminary and the academy, thinking about Islamic ethics, but between the Muslim community and the healthcare system as we design culturally responsive healthcare systems. And the challenge for all of us in any part of this is the challenge of translation of terms and concepts and needs and wants, right? So when you want to provide care for the Muslim community and they sort of say these things are needs and desires of ours, and we say, okay, well, if they're needs, then they're not priorities. There's all this lingo that comes in the middle, right? And then we think about, well, how do we then build a healthcare system that's responsive? So near the end of my talk, I'm going to kind of suggest certain types of knowledge gaps there. But the first part is just general knowledge gaps about Muslim healthcare disparities. They're mostly known unknowns for various reasons, and I'm going to use data from the United States to talk about that. And there are some known knowns, right, that we do know the impact of Muslim identity in health and healthcare seeking behaviors. The latter part of the talk is now addressing the policy level questions and the gaps there. So when we think about end-of-life care and healthcare decision makers, there are differences in religious cultural vocabulary that sort of trip us up. And then there are, I would argue, structural deficiencies in healthcare delivery that can contribute to healthcare inequities for Muslim populations. So in the United States, we just Monday celebrated Martin Luther King Day. And this quote, if you go to any social justice, healthcare justice talk, this quote is given up, right? So I'm just doing that pro forma, that a wise individual made this claim about the United States when we knew at that time there were a lot of inequalities in various domains, but the ones in healthcare were the most shocking and inhumane to him, right? And I still think that we in the United States at least suffer from this legacy, that there are stark inequalities in healthcare. So healthcare inequities are, differences in health status or medical treatment. This is an empirical question. Are there differences in health statuses between different populations? Do we treat certain patients differently in the healthcare system? And this latter part of the definition are that they are unfair to disadvantaged people and avoidable. And that claim is a normative assessment. There's something wrong about this difference that needs to be remedied. There's something wrong about the way that we're treating these preferences for patients that leads to something that's to some avoidable quality of care deficiencies. So when we're talking about healthcare inequities, we're engaging in an ethical sort of conversation based on some empirical data. And as I said, there are known knowns and known unknowns largely around the empirical questions that we have not yet focused on what data we need to think about the ethical question. So what is known about Muslim healthcare outcomes in North America? So we did this many, many years ago. I just, as a fellow, I was thinking about, well, what do we know? Right? So the standard is taught, just do a literature review. So we said, okay, let's do a literature review about American Muslim health disparities, including Canada and Mexico. And you just put this term in PubMed, which is our main bibliographic database for providers, for healthcare providers, you'd get 2 articles. And then if you did Muslim and American disparities, you get 10 articles bounded from 1970 to 2009. So in this sort of 40 years of research, and if you just put that term in, you'd get 2 or 10 articles. That tells you nothing, right? That would tell you nothing. So I said, well, we got to move beyond this. Maybe the issue is that the Muslim term. So we then said, let's use ethnic or racial geographic origin proxies. So Nigerians, South Asians, Arabs, and go forth that way. So we got a few more papers, 171 papers that were empirical in nature. 26 of them were from Canada, the rest were US based. Mostly the research was on Arabs or South Asians. meaning that the papers themselves didn't talk about whether there are Muslims within that population or not. And we know that most Muslims, most Arabs in the United States are not Muslim. Most South Asians in the United States are not Muslim. So when you're trying to make some decisions, policy decisions, around these data, you would know nothing about Muslims, right? Or you could not posit correctly what is the Muslim aspect here. And only 19 of these 171 papers consider religion to be potentially contribute to healthcare differences at all in these populations. Only 19. So there's a dearth of literature out there, right? A gap about what religion contributes to healthcare disparities. Now, why is that in the States? It might be different. We were talking about this at dinner. Maybe it's different here in Canada, but I would assert maybe not. That you have a challenge of finding Muslims, right? Because we don't collect data nationally that incorporates religious affiliation, at least in the States. And our national health surveys done by private companies and universities don't do that either. There's a history to that, worrying about religious discrimination, so they just decided, well, we won't collect it, so we won't know. Naming algorithms, and my own research group and the one that we had done some naming algorithms using geographic origin, country of origin, and plus last name, and we found that our hit rate was 9% or 15%. So to use that would be, to try to do that for Muslims, meaning that 1 out of 10 people we identify are Muslims in a data population from a healthcare insurance data set, that would cost millions of dollars to do any research, and no one would fund that because of poor specificity. And then you would miss all the indigenous African Americans, right, who don't change their names. Regional or local projects are problematic in our Muslim community itself because we don't have the infrastructure for systematic or longitudinal research. I've done this for now 10 years, 6 years on a breast cancer project. I started off with 13 mosques in my study. I ended up with 2 by the end of 6 years. And that investment was $600,000 by an agency. To say that at the end you did an intervention at 2 mosques when you started with 13 is a problem, but no one's there for 6 years. All the people left that you started off with on your advisory board. And so this creates a big problem to generate data. You start from the ground level up. Lastly, the metrics that we use to assess religiosity are not adapted for Muslim populations. They're basically generated from Christian groups, and then we map them onto Muslims. Even the notion of spirituality, right? We think it makes sense, it resonates with the Muslim worldview. Maybe it does, but it's not how we would first think about it. That's not the term that we would use. So in any case, they need to be validated, and because we have a lot of different ethnic groups in the Muslim community, then you have to do validation in all those groups. Again, time intensive, resource intensive, and there are not many enterprises that go on and do that. So we can't assess it. So those are the known unknowns. We can't get at Muslims nationally. We can't get at sort of Islamic religiosity. We don't have an ability to create infrastructure for a long-term research project in the Muslim community, at least in the States. And some of that is deliberate. Some of that is just we haven't paid attention to it. Now, what are the known knowns? Well, this is a theoretical model from literature reviews that I want to walk you through. And basically, the gist is that Muslim identity influences health in many ways, and there are a lot of papers that talk about that, but you have to put them all together. So in one way, starting here, and maybe you can't, I think the slides didn't project very well, but it's health practices rooted within the Islamic tradition, and at the end you have healthcare or health inequities. So I'm going to walk you through an example, and all the examples I use are research-based. A paper will talk about this, of how you get from here to there. Okay, so let's start. So think about healthcare practices in a Muslim context. There are many Muslims who fast. There are many who believe the prophetic notion that black seed has a cure for everything except for death. So they have health practices that are outside the healthcare system that they use to prevent maladies or to cure maladies. Now, when they come into the healthcare system, right, maybe you don't ask about them, because they're going to ask, do you do worship-based practices for health? And when you ask about alternative treatments, many of us don't. So we don't know about them. But it is quite possible that there are certain types of formulations of black seed that might have effects with your Coumadin. And have you not asked, right, you might find, why is this person always having an INR that is too high or too low? Because of the lack of asking about this, because no one would say this is a sort of you wouldn't think of it. You would ask, I wouldn't think of it, right? And so then I wouldn't ask them, then no one knows. But yet we know that there are some challenges here. So for example, there's a study about individuals with cancer. They decided that we're going to use certain worship-based treatments, and that caused a conflict within individuals. Well, do we accommodate that, knowing that it might have effects, unknown effects upon our chemotherapeutic regimens, right? Or do we tell them to stop that? And when you tell them to stop that, then they say, well, why are you taking things from our religion out of the equation? We don't want to come to your hospital. We'll go to another cancer center that allows more integrative therapies. Okay? So that's an example of where just a health practice within the tradition can cause an ethical cultural conflict in the healthcare system. Looking at the bottom here. So religion-based interpretations of health or lack of health also influence sort of not only conflicts in the healthcare system, but also patterns of healthcare seeking. So for an example, there was a study of Somali individuals where they talked about, this is a healthcare center in, I believe it was in Minnesota, where they noticed amongst their own clinic that Somali patients were less likely to take contraceptives after pregnancy, right? Because you give people contraceptives, you just had a childbirth, they wouldn't take it. And when someone did qualitative work, they sort of said, the term was, pregnancy is not a disease. Why are you giving me medicine for a disease? Right? So this notion of, well, how I can think about pregnancy, or do the opposite. If I think infertility is a disease, I might take things. But if infertility is not a disease, but is something that God gives or grants, then your healthcare patterns of seeking for those maladies would be different than other populations. And when you're in the healthcare environment, it might lead to cultural conflict. The standard of care is that now I give you 30 days of XYZ post-pregnancy, right? Say it were. Maybe it's not here. But now this population is not getting that. So that's a healthcare difference. Is it an inequity? Or is it preference-based? Right? So my point here that it leads to both conflicts in the healthcare system and might lead to alternate patterns of healthcare seeking, which again create differences. Then we have to decide whether they are inequities or not, if there's a normative component there. So moving back up here, and the previous presenter talked about this a little bit. So perceived discrimination due to lack of cultural accommodation of religious values or practices, right? You can imagine that can create a problem both for healthcare seeking behaviors, this should have been the other way, and conflicts in the healthcare system. So gender concordance is the big one, right? Where there's many studies here, I've done my own, that within Michigan in a Moss-based survey, 20% of individuals, men and women, had said they delayed seeking care because they couldn't find a same-gender, same-sex provider. In Chicago, when I did this breast cancer work for 6 years, 53% of 254 women that we talked to had said they delayed seeking care because they couldn't find a same-sex provider. And so this leads to alternate patterns of when should I go to the doctor? But now, when you go into the healthcare system, there are also stories where they're not accommodated. I'm an emergency medicine doctor. When I was a resident at the University of Rochester, we had I think it was a Yemeni refugee family whose husband drove up to the ED, said, is there a woman working today? And he was told no. He said, I'm not coming here, I'm going to go to another hospital, right? Or they said, can you get someone? And then I've had these experiences as well. Well, then they say, yes, I can get someone. Then okay, then I'll come to that hospital. So my point is that this perception of accommodation of this request leads to alternate patterns of healthcare seeking, which might lead to and contribute to health differences in the population. Are they health and care inequities? Well, we have to decide, should we accommodate this value or not? So lastly, let's talk about this thing, Islamophobia. So just being a Muslim outside, wearing a hijab, having a beard, or being construed to be a Muslim is an adverse health risk. Just being Muslim. And there are plenty of studies on this. Whether we want to choose to focus on that or not, it exists. Discrimination and abuse leads to poor mental health outcomes. I did this own work back before the current stuff, but in 2009 in Michigan, the higher risk of mental disorders in populations because of experiences of discrimination or abuse within themselves or their family. So that leads to then delayed preventive healthcare seeking or acute healthcare seeking. Or bad behaviors. You might then start smoking or drinking or whatever else it might be that will lead to poor health outcomes. So you see this is known from various studies, but we don't have research that then works through this model for our populations. So all of this, I think, and have you seen this? Have people seen this film? No? Yes? Okay. So I think this film is an amazing film that talks about a healthcare environment. It's about 55 minutes. We use it as a teaching tool at the University of Chicago about cultural competency. And I encourage you all to see it. So I don't want to give you away the punchline. But the point is that there are 3 different events that happen. And there's a guide online to how to talk about this, where this religion and cultural mix is not properly addressed by the healthcare group and leads to differential outcomes and understandings. And there's also family dynamics there as well. So you haven't seen it, so we won't talk about it, but take a look. It's a good film. And I don't get any royalties for that either. So the question here is, right, so we all, as people who want to service our populations, we all like this notion of healthcare accommodation. Let's make cultural adaptations that would make patients more comfortable. Let's modify healthcare delivery based on patient values. But where the rubber meets the road is what values, to what extent, and how, right? So if there is a value that we want to provide gender concordant care, you say I can't do it, but maybe for rape victims we can do it, or maybe we can do it in the L&D, labor and delivery, for certain populations, right? We won't do we won't do life-sustaining measures for certain populations, but maybe we'll do it for certain alternate treatments for other populations. You can talk about it, but the point here is that it's not known what values, right? We might do circumcision in the hospital for certain groups, we might not do it for other groups, whatever it might be, or we might do, and I don't want to go there, but you know what I'm thinking, right? So for certain genders and other, whatever it is, there are values that are in the conflict and debate. And so we can think about pluralism all we want, but we're not ethical relativists. And so this leads to this question that is unaddressed in the bioethics literature. Okay, so now, I already put that aside before, so let's move to a little bit now. I took you sort of the policy question, let's talk, and how we might contribute to disparities. Let's talk a little bit about Islamic bioethics and some empirical data I'll splice in. So Islamic bioethics, as I define, is a discourse that uses the Islamic tradition to address moral questions and ethical issues that arise out of the biomedical sciences and allied health practice. So usually it involves someone from the medical field, right, talking to some Islamic authority. Now, there might be different types of authority, it might be someone with no authority, or just assumed authority, but something like that. And oftentimes in the discourse in Islamic bioethics, it's usually a physician voicing a question that's a patient's to the scholar or their own, and there's some religious scholar. Now around them are a group of scientists, right, who sort of think about this encounter in many different ways and analyze the output of that encounter. One output of that encounter would be a fatwa, for example, right? Another might be some paper, another might be just some conversation, right? That an open question that has no answer. So within that, I'm going to show you that the problem for us, let me move back, or the problem for us, well, this is the problem for us. So the last slide talked about the interaction between doctors, right? So I did a national survey of Muslim physicians in the United States, and I wanted to see how these actors act, they talk to each other, and what the knowledge gaps are. So this is data from Muslim physicians, national sample in the United States. So in this domain of end-of-life care, they struggle. Here's one aspect of that. 31% of this group did not know if life support can be discontinued at the end of life, from an Islamic perspective. 31% did not know whether tube feeding can be withheld at the end of life, from an Islamic perspective. 54% felt that brain death was not equal to cardiac death. Right? 70% were psychologically troubled by withdrawing life support. So this is the Muslim physician population in the United States, who often are the conduits for the patients. And they have a lot of challenges in end-of-life care. And oftentimes they are assumed or presumed to know the Islamic XYZ, right? But here you can see that they were disquietude within this domain, but maybe they didn't know, a third didn't know about certain aspects. Okay. Now, I could say the same thing from the perspective of the jurists, right? Where you have these jurists who think about, there are opinions, brain death is legal death in Islam. There's another opinion that brain death is a dying state. And you can review those sorts of, those fatwa and those decisions. And you, as a physician, you say, okay, well, how are they thinking about, what's their imagination about medical science or about brain death? And you'll find that there is a point where they have conceptual gaps as well, right? That influence these judgments. So what's the difference between a prognostic and diagnostic entity? Is brain death a prognostic entity or is it a diagnostic entity? In their deliberations, they don't have any notion of that, which it is or even what that means, right? And I would argue that it's a prognostic entity, not a diagnostic one, right? And you'll see why in the next few slides. Is it death an event or a process? We know in the bioethics, this is a question, and we talk about society, right? So what is it? No real conversation about that in the medical realm. Is it an event or a process? Is irreversibility, what is irreversibility in relation to cessation? So a patient comes into the emergency department, they have a DNR, I decide that I'm not going to, and their heartbeat is not palpable, I decide I'm not going to do anything. Is that state irreversible? I'm not doing anything. Yeah, it's irreversible. But what does that mean when you translate that into the into the fatwa around brain death. So these concepts weren't worked out very well. These conceptual gaps remain, and you get verdicts like this, that brain death is legal death, fine, but they say, well, how? All vital functions of the brain cease irreversibly and the brain has started to degenerate. Well, what are the vital functions of the brain? What do you mean by irreversibility? We know there's studies, Dr. Schumann has done some from Harvard, where certain brain reflexes come back, right? What do you mean by brain has started to degenerate? No one goes out and does a biopsy of the brain as part of the brain death sort of adjudication or assessment, right? So you get a fatwa that is fine. Brain death is legal death with all the religious backing. But what they say for you to apply in the medical arena is something that's not applicable. Doesn't make sense. So the religious ruling or rationale might be great. But what are we left with? Something that I don't know how to make sense of in my world. The other side is a little better, I guess, unstable life, right? So it's between dying and death. So they say if a person has reached brainstem death, some of the rulings of life, unstable life apply. They specify withdrawal of life support is permitted. Very good. So some clarity. I can withdraw life support when someone has reached, they specify brainstem death. But now what about all those other cases? Where we have a pregnant woman who's in her 30th week and we can keep her on for 2 more weeks and then we would have a better outcome of the child. Am I permitted to keep her on? Am I not? Right? What about kids where brain death is a little bit more is tricky? How do I think about that? What about organ donation? So you get questions that are not addressed. And this is good if they don't want to address them because they have to do more work. But the problem becomes that we are left with a gap now to apply the same way. Some of the rulings, what do you mean some? I don't know what unstable life means in Islamic law. So how am I to decide what rulings are there or not? So at least, as I said, so at least some confusion around what to do at the bedside. Because both the jurists and the physicians have conceptual mismatch in their vocabulary. And that can lead to healthcare inequities as well. Because oftentimes, in my own experience, right? Oftentimes, who is asked when there's a troubling case of a Muslim patient? Find the Muslim doctor in the hospital, right? Well, let's go find that imam at that mosque, if we know that mosque. But what guarantee do you have that they know either, that they even understand the conceptual framework of the hospital? Okay. So as I said, they're not only they have gaps, but they're disconnected, and I think this needs to be remedied, right? So look at this from the physician perspective. 55% never really read Islamic bioethics books. 64% never really consult jurists. Almost 80% never really read these medical fiqh academy verdicts, right? So their sources of knowledge, of ethical knowledge, are not what we think they should be reading, or maybe they think this is not quality work, so we shouldn't read it. So there's another they're not talking to each other and they're not even looking at each other's material, at least from the physician side. Moving now to more general up. So we started with empirical questions, policy relevance of healthcare disparities, to now the Muslim phenomenon of these two sort of healthcare stakeholders. Now I'm going to talk about the lexical and cultural challenges of this domain, which I think are a lot. So, our vocabulary is informed by, centuries of understandings. Right? Our conceptual vocabulary is informed by centuries of understandings. And I don't think that we recognize that when we have a conversation. You heard some of that today. But, right, in some aspects, what was happening in the healthcare system is we are having all these cultures come together with their own conceptual understandings or the cultural understandings. And we think sometimes we're having a conversation, but we're talking past each other. Right? But when we want to deliver healthcare, we have to come up with a lexicon that's shared. Right? Suffering. What do you mean by suffering? Right? What do you mean? Is it a biological phenomenon? Parenthood. Right? Is parenthood chromosomes? Or is it a social construction? Right? I mean, these are things we're dealing with today because we've gone beyond our capacities of what we used to think about in traditional societies. But this is reflecting upon the Muslim culture as well. So let's talk about a couple. Spiritual support versus religious guidance. I'm going to give you stories with each one of these. Right? So I was at this wonderful conference. These guys are Saudi, they're not going to like me saying this. But anyway, I was at this wonderful conference, invited to this wonderful conference. We had people from the highest caliber people coming from the United States, Skyping in even, right? Talking about setting up chaplaincy in the Kingdom of Saudi Arabia. And they were talking about providing spiritual support. right? And they're talking, and the Saudis, and the people on the Saudi side were saying, oh, we have this, we've done this, every hospital has to have someone doing this now. So they're having wonderful conversation. And I have an observer, I'm thinking, okay, very good. They're talking about chaplaincy, which is non-directional, right, a-religious, and here you're talking about Murshid ad-Dini, who wants to rectify someone's theology before he dies. They're not talking about the same thing, but they were so happy they had a joint statement at the end. That we all support spiritual support for people at the end of life. And that's the phenomenon. That you're talking about something which doesn't make sense in your cultural baggage, but you think you're talking about the same thing. But you're not. Right? And then that becomes a problem here. Today, we want to have Muslim chaplains. You know, I go to the mosque and I tell people, well, Muslim, they're like, well, what's a Muslim chaplain? Like, who's that? Where do they come from? And I will even tell you, people say, this is just, believe it or not, they've told me, I interview patients, Muslims in the community, right? This is part of my job. This is some, subversion by some people to change the religious authority structure in our community. That's what they say. So we don't want to talk to them. We don't want to give them any sort of authority structure because of this. Right? Okay, death with dignity, aid in dying versus, this is, you all know this better than I know, right? Canada is dealing with this, right? So Imam asked on radio show, do you support death with dignity? He's like, yeah, I support death with dignity. Do you support, physicians helping people die? No. So what are you talking about? No idea, right? Because the vocabulary is used for certain sort of understandings, but they don't have. And so we can sort of then frame it in a certain way and get the answer we want and stop with the second question. This Imam said, he supports death with dignity. We're done. We're good. We got the fatwa. Move on. All right. Okay. End-of-life care versus transitions care versus palliative care. So I was scolded. I give these workshops about end-of-life care. I was scolded by some imams that, why are you talking? There's no end-of-life here. It's just a transition, which is right. In their view, this is just help them make the passage from this state to another state. But you all want to talk about end-of-life care and it becomes depressing, and I don't want my community to be depressed by these topics, right? And he's a valid concern. I don't think he was overplaying his hand, but that's a valid concern. Who's going to come to a depressing talk on end-of-life care? Preparing for death? Preparing to meet God? Let's do it. Let's do that seminar in the mosque on Friday evening. So these conversations, again, we have challenges, right? Because you're bringing in a vocabulary that doesn't make sense. Palliative, no one knows what palliative care is. I don't know if you know, Shibia, but those guys don't know what palliative care is. Neither imams, no one knows over there in the community what palliative care is, which is a big problem. I think the ethos of palliative care is entire total care, right? But no one understands in that community, or the communities that I've gone and visited what palliative care is. This other thing is actually empirically based, medical necessity versus religious dire necessity. So oftentimes, and I'm going to end soon, don't worry. So oftentimes, and this survey was very helpful for this, where physicians say, that we're going to use this principle of dire necessity, darura, right? That dire necessity overturns prohibitions. I can take porcine vaccines because there's nothing else available because there's a necessity of medical reasons, or I can do this or do that, right? So the scholars use it as a get-out card, right? There's a big problem. There's a religious dire necessity, and to them that means some sort of life threat or tangible, credible life threat or big disability, and then I don't like to use the word trump, but it's a trump card. So then suspend other rulings. Okay, doctors have gone willy-nilly with what that means, because then they say medicine itself is a medical necessity. You gotta have health, otherwise what's your life? And so they use it willy-nilly. And then I sort of did a study. Okay, let me see what's going on. And I found out in the same, I'm not showing the specific table here, that here was a sequence of cases. Is there medical necessity? Is there a religious dire necessity? What would you recommend? So for these controversial procedures, like abortion or whatever else. So you would find that whatever the physicians judged medical necessity, that correlated to them recommending to do the controversial procedure. But there was no correlation between dire necessity, darura, and anything else. Meaning for them that concept makes no sense and is not necessary for their practice. They're not informed by that concept. Yet it is the thing that the jurists give us to use. It's the tool they give us. When you find a problem in medicine, tell your patient there is a necessity, but they're not using it, at least in the United States. Okay, so now the structural challenges and disconnections, right? So I don't know very much about the healthcare system here aside from what I've read in some papers, so I don't have experiential knowledge. But at least in the United States where I come from, if you were to say in the communities, even at my own hospital, you serve this amount of Muslims, do you have a proportionate number of chaplains, if you believe in Muslim chaplaincy, to serve that population? And you'll find no. And you ask why? Because Muslims haven't created chaplaincy programs. Or we don't, right? So it's a connection problem. We haven't created chaplaincy programs, and they say we don't have it. Or they don't need it. So patients don't need it, right? They always have the imam. Why do they need it? So it becomes this sort of problem of delivering this authority structure or this support to patients. Then same thing on ethics and Islamic ethics consultations, right? So as I said, the Muslim doctor will be called in to ethics. We have an ethics committee at the University of Chicago, like a very robust one. And so there's a patient problem with a Muslim population, and that person becomes the Muslim doctor. And then you say, what are you talking about? And well, is it Islamic ethics you're talking about? Or are you talking about some other ethics? What ethics are you talking about? And all of a sudden you're placed in this position of I'm speaking for this global population, which I might not have any notion of. And there was a case in Michigan where, this is the story here, that a very nice ethics consult committee said, let's find that Muslim doctor. The Muslim doctor went to this patient in end-of-life care. And that patient family said, that the brain death had been declared, and they said, okay, we don't accept brain death because our religious leaders say no. That Muslim doctor said, well, look, I have this imana, whatever pamphlet that says brain death is okay in Islam. And so there was a conflict. And the health Christian said, well, they're just using the religion card. There's no basis here. Look at all these guidelines that we can find. And then they withdrew life support, which they had legal right to do, but it became a bad sort of situation for the family and the community. Later on, you find out that they'd been in conversation with someone in Qum, talking, right? So they didn't care what any pamphlet said or anything. Their religious authority was back home, but no one had talked about that. And that Muslim ethicist, or whatever it was reprimanded for playing out, talking about religion. So where do you want? So my point is that the healthcare system, there's inequalities. What do you want? If you're going to bring me in as an ethics consultant, which part of me do you want? You want me to be the communication specialist, the cultural liaison? You want me to be the Islamic ethicist? What do you want? And no one specifies. That can lead to, again, inequities in care for the patient populations. Lastly, I think that Muslims generally are not at the health policy table. In my country. They're not. So the vernacular of that policy sort of conversation is just not one that we know very well. And so we are not able to make sort of health policy recommendations that are couched within liberal, democratic liberalism. Really, we can't. So with that, I'll end. I think I did my time again. Well, yeah. So I'll field any questions.
Thank you very much for the presentation. So I have a question, actually. I'm curious about your study that I'll definitely read afterwards about the Muslim physicians and struggling with end-of-life care. And so one of the stats was especially, I was drawn to it, the 70% of physicians were psychologically troubled by withdrawing life support. So I wanted to unpack that a little bit to better understand why. And I'm not sure if that was also part of your analysis, but part of me, or maybe just based on your experiences, if you could speak to the reasoning behind that very high number. So part of me was thinking, drawing from your previous presentation as well, was this because of the potential for personal subjective suffering, right, based on what may be experienced afterwards in the afterlife? Or was this because of this medical necessity versus religious dire kind of, dilemma? So just if you have any thoughts on that.
So that, very important data point, and I didn't do interviews focused on that data point. The data point right before that was about brain death, and so I have a speculation that this quietude with brain death is part and parcel of that relationship with withdrawing life support. Right, in the United States, only 2 states, and this is a quasi-third for interesting reason, have exemptions, right, for brain death. There are prominent Shi'i physicians, Shi'i jurists who don't accept brain death. And so this moral couple, and particularly that study, part of the sample, some of the samples from Michigan, so I can assume that this maps on in a certain way, not only just the religious notion of what brain death is, right, not dying, not death, but dying, but also just this quietude around what brain death represents. The other point is that, and this is from an interview, where a ICU physician told me, and as I told you, like we do a lot of persuasion in the ICU, right? It's not so much, and I think we like to think that information just giving them data tables makes people make informed choices. But they don't necessarily have the literacy to do that, and it's just us who feel better doing that oftentimes. So this physician made a very interesting quote that stuck with me. So that he said, every time I engage in that family discussion with a Muslim family, I wonder, on the day of judgment, how many of them are going to come and take recompense from me for guiding them the wrong way? Right? Because he knows that there's a 10% or 5% chance, but who is he to decide? But they want him to make that decision, right? And so you get this sort of notion that I fear for I want them to make the choice, I give them the tables, what comes back, you make the choice, and then whose statistics am I using? What am I doing? And so it causes a lot of disquietude there around these sorts of fuzzy things, right? Minimally conscious state, around whatever else it might be. So that's how I would speculate the reasons are for this sort of disquietude with withdrawing life support in the United States.
So thank you so much for a great presentation. A lot of food for thought, a lot of questions that obviously require answers. So I'm a critical care physician, and I'm going to try and be a little bit provocative. So I'll say that after 20 years of being the Muslim ICU physician and sort of brought to the bedside of difficult family conversations because the family or the patient is Muslim, what I now tell my colleagues is that whatever challenge you may be having with patient X, family Y, there's a 99% probability that it has nothing to do with Islam. The vast majority of the conversations that I find myself having with people are about personal wishes, perspectives, and people are using, and I say this in completely value-neutral terms, but religion is being invoked as the rationale for that position. But the position is personal. So I don't know if you've had similar experiences.
I share that experience. I think that all ethics consultations, I mean, I'm sure many people here serve on ethics committees, is communication. Right? There's a lot, that's what, I mean, all the time I can think about in the 7 years at McLean Center, sitting in those case conferences, like probably on my hands, I can say there's a real religious issue here. I'm there for most of them, right? But there's just communication impasses, lack of understanding on both sides, right? That's all that's happening. So that's just the reality, that we're all human beings. We're confronted by, things that we don't quite understand, and no one really takes the time to explain it to us. The religion thing, I do think one notion that there are some communities that actually know very well what they want, right? Michigan again, where there was a Yemeni community that ended up deciding by market force not to go to a certain hospital because the nursing staff there was very not accepting, again back to the first slide, not accepting of their request to turn the patient's bed towards Mecca when they're dying, because that would mean that the monitor would have to move so that they can't go around and just see. They would have to actually step into the room to see the vital signs. Now, that's not a big request, but it was one that the nursing staff had decided, not even doctors, we're not doing this because there's a patient safety issue. That's it. That hospital doesn't really care about our values, we're moving on. Right, so I think, and they said what? They're not accommodating our religion. And our religion tells us that we should turn the patient towards Mecca when they're dying. So there are some real things that are used to sort of say, hey, our religion's under assault in this political context, and this is what you're doing, and then that leads to healthcare behaviors that are not good. So I do think there are some, but I agree with you. My experience is the same. That's 99%, but the majority are just communication gaps. Anything else? Thank you for your rapt attention. Appreciate it.